Hello everyone and welcome to another Muslim Medics video tutorial. Today we'll be looking at the pharmacology of antiarrhythmics. Just the usual disclaimer, this is a medical student-led tutorial, so anything that contradicts a lecturer's slides, just let us know and we'll check it out. Our main learning objectives for this video tutorial are to understand the mechanism of action of 4 antiarrhythmics and discuss their clinical use. So we're going to be looking at adenosine, verapamil, amiodarone, and digoxin. Before we go into our antiarrhythmics, let's quickly review the action potential of the SA node cells, which we know is the pacemaker of the heart. It starts off with the IF sodium channels, transient calcium, and long calcium channels opening, letting both sodium and calcium enter into the cell, increasing the potential of the cell called depolarization. Once it reaches a threshold, potassium channels open, and potassium leaves the cell, causing repolarization, often so much so that the cell becomes hyperpolarized. And then the cycle repeats itself. The SA node acts as a pacemaker, causing atrial contraction, and sends signals to the AV node, which causes ventricular contraction. Our first antiarrhythmic is adenosine. Adenosine is often used in acute settings to allow patients with supraventricular tachycardias, so that's tachycardias that originate above the ventricles, to return to a normal heart rate, which is between 60 and 100 beats per minute. We need to do this because if someone's heart rate is consistently above 100, it can cause heart failure, strokes, or even sudden cardiac death. When someone presents with an SVT acutely, if they don't go into sinus rhythm with measures such as vagal massage or an ice bucket wash, adenosine is administered intravenously, which causes transient heart block. So the way that adenosine works is that it binds to A1 receptors on the membranes of SA node cells, which are coupled to G proteins. Through these proteins, adenosine inhibits adenylyl cyclase, which is an enzyme converting ATP to cyclic AMP. By inhibiting this enzyme, adenosine reduces cyclic AMP, which then inhibits L-type calcium channels, and therefore stops calcium entry into the cell, which we know is needed for depolarization. It also stimulates potassium channels, which causes potassium efflux. Overall, this causes hyperpolarization of cells, reducing the rate of action potential transfer. By slowing down the conduction of irregular rhythms and electrical impulses generated in a supraventricular tachycardia, adenosine can bring patients from an SVT into sinus rhythm. The only other thing to consider is that adenosine has a very short half-life of only 10 seconds, and therefore it is not a treatment for chronic arrhythmias, only acute SVTs. Our next antiarrhythmic is called verapamil, which is a calcium channel blocker. There are 2 main types of calcium channel blockers, non-rate slowing and rate slowing. Non-rate slowing blockers cause relaxation of the smooth muscle in the heart and are mostly used for angina and blood pressure, so we won't go into much detail about these. Rate slowing blockers, however, as the name suggests, slow down the heart rate by acting on the SA node, and also reduce contractility by acting on the muscle cells. So they have 2 actions, but we're more interested in its actions on the SA node. Verapamil comes from a class of drugs called phenylalkylamines, and it works by blocking the long-type calcium channels in the SA node cells. If this is blocked, there will be less calcium entering the cell, slowing down the rate of action potential, and therefore slowing down the heart rate, which is of course what we want in a tachyarrhythmia. So, verapamil prevents the SA node firing off rapidly, and we know the SA node excites the atria, so verapamil is mainly used for atrial tachycardias, like atrial fibrillation. Before we speak about our next drug, let's have a quick reminder of the cardiac myocyte action potential, which is different to the SA node potential we spoke about earlier. Depolarization is caused by sodium channels opening, causing sodium influx. Then repolarization begins by potassium and chloride channels opening, causing them to go out of the cell. And you then have a phase of hyperpolarization, when action potentials cannot occur because it's below the threshold. But the delayed repolarization is due to calcium channels opening, causing calcium influx, which keeps the potential positive, which is why it looks slightly different to other action potentials, which are steeper. This is a series of steps that take place each time a cardiac myocyte contracts. Now that we have a bit of background, let's talk about our next antiarrhythmic, amiodarone. This drug works on cardiac myocytes and, similar to others, prolongs the action potentials of these cells. Amiodarone delays repolarization by blocking potassium channels. By slowing down the action potential process and prolonging the refractory period, we can slow down the conduction rate, or the number of action potentials per second, and so reduce the tachyarrhythmia. Amiodarone has a very complex mechanism of action, as it acts on lots of different receptors, such as beta-adrenergic receptors, thyroid hormone receptors, but the important thing to remember is that the overall effect is prolongation of repolarization, slowing down the conduction of action potentials in cardiac myocytes. Clinically, amiodarone is especially useful in situations where there is a re-entry circuit. Let's briefly explore what a re-entry circuit is. Normally, when an action potential conducts through cardiac tissue, it travels in one direction, and if it splits through the tissue, it splits, propagates in one direction, and then joins to become one again. What stops the action potential going backwards is, as we discussed earlier, hyperpolarization, or the refractory phase, preventing any new action potentials taking place. Now, if the cardiac muscle is diseased, whether that's ischemia or inflammation, this can cause the refractory period to become shorter, which means the action potentials can go back up the wrong way and then get caught in an endless cycle. So the pace of the heart is no longer set by the SA and AV node, rather is being set by the re-entry circuit. Now, this can be small scale in a small amount of tissue, or it can involve the whole heart, which can lead to ventricular failure, and this is fatal if not treated. So drugs like amiodarone, which prolong the refractory period, are ideal to break the re-entry circuit and allow the SA node again to set the pace. So in summary, amiodarone has a complex action on multiple ion channels, but the overall effect is that it prolongs the refractory period and delays conduction of action potentials. Our last antiarrhythmic is digoxin. Digoxin has an impact on the contractility of the heart and can be used in heart failure, but we won't look at this use. Rather, it's used as an antiarrhythmic. Digoxin stimulates the vagus nerve, which we know is parasympathetic, and so reduces heart rate. It does this by reducing the rate of conduction through the AV node, leading to an overall decrease in the speed of conduction. Since digoxin's main mechanism of action is to reduce contractility, it is not a first-line antiarrhythmic. Rather, NICE recommends it if somebody has atrial fibrillation or an arrhythmia alongside heart failure. So in summary, adenosine is used for acute SVTs, as it has a very short half-life, and it works by hyperpolarizing cells to reduce the rate of action potential transfer in the SA node. Verapamil is a phenyl alkylamine calcium channel blocker, which prevents depolarization in cardiac cells, again slowing down action potential transfer. Amiodarone has a complex mechanism of action, but it works by prolonging repolarization of SA and AV node cells to slow down the heart rate. And lastly, digoxin stimulates the vagus nerve and has parasympathetic effects, which slows down the heart rate. Thank you for watching. This has been a quick run-through of the pharmacology of antiarrhythmic drugs. We hope you learned something. Make sure to like, comment, subscribe, and join us for another Muslim Medics video tutorial.